Aberdabaw, John Williams dwi, Cadeirydd y Bwrdd, Corff Llywodraethu Iechyd Presnogau Abertawe. Croeso cynnes I cyfarfod y bwrdd bore yma, a croeso mawr i'r arsylwyr ar-lein gyda ni am y tro cyntaf heddiw. So, good morning everyone. I am John Williams, the chair of the board of Swansea Bay University Health Board, which is the governing body of the organisation. And a warm welcome to today's meeting, and particularly to those joining us online. We are live streaming today for the first time, so we are very pleased to have your company this morning. So the board, as I've said, is the governing body. It's the highest level of decision making, spends nearly £1.8 billion of public money and employs around 14,000 staff. And we are responsible for providing health services, reducing health inequalities and improving the health of nearly 400,000 people in Swansea and Newport Talbot, and a significantly larger number of people for our regional and specialist services. And this all makes us one of the largest public bodies in the UK. The board works to three different time horizons: the long term with a future focus, the medium term, and the here and now. And there are times when those agendas overlap, and they do today, later on in our agenda, around our maternity neonatal improvement plan. We always have to apply a population health lens because we have a statutory duty around public health and health protection. And today we are going to be alerted to the inequalities in our population, premature mortality from cardiovascular disease, and we're also going to be told of the importance of a system-wide approach to tackling obesity. The board sets direction, and we always set strategic risk associated with that. The board sets the risk appetite, and then we do this to make sure that the objectives we set match with the risks we identify, and then we keep these dynamically updated as meetings go ahead to make sure that we never lose sight of strategic risks. In terms of our strategic direction setting, we now have an established part of the board where we take a planning and partnership report. And we're going to hear today of the preparations for our 2026-27 annual planning round, because this is a very, very important planning round for the board. We also look at delivery against our in-year plan, and that's got to cover safety and quality as well as performance and finance. We must look at all these matters in the round. And we have a milestone on our agenda today in the production of the final maternity neonatal improvement plan. The board held a special meeting in July of last year when we took the report from the independent review panel. We accepted the recommendations in full, and the plan in front of us today sets out how we are going to implement and respond to all those recommendations. We have colleagues joining us for that because it is a particularly important day for women and families and for the whole community, as well as our staff. So we are also going to be taking a majorly important report on finance. The board has two non-negotiable targets it has to meet at the end of March: to make 55.4 million savings and to make sure we do not end the year more than 58.7 million in deficit. The deficit comprises three different components: operational management, strategic and structural matters. And the board today will be looking at all aspects of delivery around reducing the deficit and making sure we hit those two non-negotiable targets, because not just for the end of this year, but for setting us up for 26-27. We, as I said earlier, have 14,000 people under our employment, so we always have a section on our people. And today we're also going to be looking at how we organise ourselves, because we need to organise properly for success, and we need to make sure we have the right people in the right place at the right time. And we're going to hear more about how we're preparing for that. Now, the bedrock of any well-run organisation is good governance. So So we always have a good, strong section on governance. We pick up the work of our committees because they do a lot of heavy lifting for the board, and we have AAA Assure Advice alert reports coming from them, and we also take all governance matters in the round. And today we will be joined by Audit Wales colleagues as we take our structured assessment for 2025 and the Audit Wales annual audit of ourselves. And this is an external way in which we test the health of our governance. And then finally, but most importantly, we set the tone and culture in conjunction with our staff. We want to come to work every day without fear of disadvantage or discrimination, and we want them to thrive, not just to come and be present. But the board has a responsibility to set tone and culture and to make sure that we keep grounded and that we understand what is happening at the front line. That's why we all take either a patient story or a staff story. We have a link today to our maternity neonatal improvement plan with that. So we've got a very hefty agenda. We did take a couple of items off so that we can give more time to finance and performance. We'll bring virtual awards and community by design paper back in March. So I will now turn to our agenda. We've had apologies from Martin Lloyd, one of our independent members, Helen Annandale, an associate board member, from Jill Richardson, Public Health Director, and Chris Morrell, Director of Therapies and Health Sciences. And we welcome Hugo von Verden, deputising for Jill, and Alison Clark, deputising for Chris. And we're very pleased to say hello to two medical colleagues who are joining us, Dr. Mina Saad and Mr. Ishtaq Mohammed. They come to observe us today, and in the breaks, please ask any questions that you want or at the end, and we hope that you find it of real interest. And as I've said, we welcome everyone who's joining us online for the first time. So can I ask, please, are there any declarations of interest not already on our register on today's agenda items? Oh, thank you very much. Well, happy with that, I'll turn to you for the Chief Executive's report, please.
Great, thank you very much, Chair. So I'll take it that colleagues have read my report, and this is an opportunity for me to set out some of the important issues and that we are focused on as an organisation, many of which follow through in terms of more detail in other items, but it enables you to find a summary of the key things that we are focused on. And Chair, if I may, I just wanted to touch on a couple of things and draw colleagues' attention to it. So I know that Deb will put this up as part of the integrated performance report, but I just wanted to put on record my thanks to staff who responded extraordinarily well to the pressure that we've seen, particularly between the New Year period until we stood down the business continuity. We have seen a significant increase in the demand at our front door. We're working very closely with WAST and our local authority partners, because obviously it's a flow issue about making sure that we only admit those patients who really need an acute admission, and we ensure our patients get home for those that are ready to go home in a really timely way. So I know the staff worked extraordinarily well. As part of our escalation, we're required to do a review of business continuity, so we will do that. We've also been part of the National Winter Sprint, and we're currently in the middle of the second sprint. And again, there's national learning around what organisations have achieved as a result of that focused attention over that period. And under Deb's leadership, we have come through the VCR, and I'd just like to put that on record. And then three other final comments, if I may. Just touching on Gorsynan ward, colleagues will be aware that we have temporarily moved the ward to Ward 3 in Singleton. A number of us are visiting regularly and have been out to visit to meet with patients and staff who have been part of that transfer. Again, very grateful staff that's really supported that move, and the Newport Talbot and Singleton Service Group in particular have really enabled and supported that change to happen. We will bring back forward in February an update because the original decision was around to the end of March. There's been a lot of work ongoing, and we'll bring back to the board in February a recommendation about the position at that point. In relation to our joint work with HALD, our regional committee sponsored work programme, paper covers where we are on our regional pathology work. And again, if colleagues will recall, it's about this time that we had the Ministerial Advisory Group meeting with us. And one of their key recommendations for us was about ensuring that we had a sustainable pathology service and a regional service addressing both the issues that we've got in terms of fragility and those in Howard R2. It's been one of the key programmes under the Regional Joint Committee. Its work is at pace to bring us the final recommendation based on the options that we have in front of us. And again, we've got a special board meeting to bring the outcome of that work so we can submit the capital requirements. Of course, there'll be a lot around service reconfiguration and remodelling, but what we really need to secure is the capital for the solution in terms of our preferred options. So we're going through that process at the moment. We'll bring that back to the board at a special board meeting to enable us to make that decision. And then final comment, if I may, in relation to mental health improvement. We've got the transformation programme formally established. There's been a lot of work over the last 9 months, as you will be aware, against a number of work streams. The action that we took in the board meeting before Christmas, so that would have been our November board meeting, was us to open up the urgent conversations with Welsh Government around capital solution. And we have had one meeting with Welsh Government and performance and improvement units, and we've got a follow-up meeting with them this coming week where we'll tease out what the options are as we move forward and how we get traction on our permanent solution. We've had some setback in relation to the interim solution that we discussed in our previous board meeting, relating to the private finance partner and our ability to get extensive works done without it incurring a significant revenue cost. So we're just again working that through, and we'll update Welsh Government and we'll bring that back to the board again as a more detailed and comprehensive update on all of the work streams at our March board meeting. We've obviously had the public accountability meeting since we last met. We've there's reference to our statement that was submitted as part of that. That's gone into the pack. I think it's in the reading room in terms of that level of detail. And we've had the Cabinet Secretary's letter. We're just exchanging correspondence back because there's something, there are a couple of points that we just need to clarify, and we will share that publicly once we've done that piece of work. And it is a bit of a disappointment that ours is the only recording that isn't actually a video of us sitting there. We didn't know it at the time for colleagues who may not be aware, but there was a technical glitch in terms of how that was recorded. So we all thought it was being streamed live and that people could see as well as hear us, but it does make it slightly difficult if you're following afterwards, because the audio recording is not as crisp as it could be if you don't know who's speaking. And of course, it's there on record. So thank you very much, Chair. Happy to take any questions.
Thank you, Country Abby. Before I open questions, welcome to Teresa Okekulu, our aspiring board member. Lovely to have you with us, Teresa. So shall I open it up for any comments or questions? Eugene and Pat.
I have two questions for you, Abby. One is around the mental health transformation programme. And the narrative that you have in the report says that we are looking at Welsh Government longer term plans. Can we be assured as board that we are looking at the here and now welfare of the patients that we currently have from a quality and safety service perspective, please? And that longer term focus won't jeopardise our own plans.
Yeah,
that was the first question. The second question was around the refer to treatment data analysis that was on page 7 of your report. The information that came about because of the Betsy Cadwallader issue, can we be assured that our work to, can we say, give us comfort that everything that we are reporting is accurate? Is that timeline being met?
Yeah. Thank you, Jean. If I take the first one, absolutely, Jean. In terms of the short-term and immediate issues. So the thing I should have mentioned in the overview was that today the HRW report, based on their visit several months ago to the Towie Clinic, the adult inpatient wards at Kevin Coyd, has been published. There are no surprises in there. It talks about good quality of the care and the care that the patients are receiving from the staff and the interface with staff. There's been some really positive comments around that. But it draws our attention again to the core environment, not just the fabric of the building, but the overarching infrastructure in which we are providing care to these patients. We know these patients might be there for some time, and we know it's completely unacceptable, the environments in which we're providing care. Some of the things, when you read the detail of the HIW report, we've got the management actions in there. So some of the things that are reported we have addressed already. So there's reference to the fact that we've not had the right kind of washing facilities for staff, for example. I've been myself, Liz and I went, and I can tell you that we've now got new laundry rooms to enable staff and the patients, predominantly patients, washing their own clothes. That's really important. And there is the programme of urgent capital works. I know it's taken longer than we would have liked to go through the procurement and securing the contractor to do the work. And clearly one of the constraints is doing works in an environment where you've still got patients. So that has been worked through very carefully with the service group to make those improvements. And I've asked the team to make sure there are touch points every week to make sure there's any problems or any other issues that come about are addressed as part of that. The quality and safety work, Jean, we should look at the key metrics that will enable us to know, are there any flags that we should be concerned about? The work stream on workforce is separating out the particular workforce issues that we need to respond to in terms of the adult mental health inpatient unit. So there's work progressing at pace in respect to that. I don't know whether Liz will want to say anything about that, but we're focusing that as the priority and making sure that we've got the right staffing model to make sure our patients are safe and responding to the fact that the environment is not as it needs to be. And we know we've got some gaps and some vacancies, and we're working that through with the service group. It's probably useful to also note, I know colleagues around this table will be aware that that board development session that took place recently was an opportunity for us to hear firsthand from colleagues who work in the adult inpatient wards at Kevin Coyne. I think it was a great opportunity, as we've done with the ED staff 12 months ago, for them to tell us that what their experience is day in, day out, working in those environments and the pressures and challenges that creates. And again, Jean, making sure through the transformation programme and the work streams and our regular business as usual quality and assurance work and our performance review meetings with service groups, that we pick up any flags that are coming through. We've also got things like the coroner cases and HIW, other things that come through out with inspections that give us insight and intelligence that we can triangulate as well. Thank you for that question. On the data issue, we've had report into Chief Exec's group in terms of the experience, but I wonder whether Deb and Matt might want to comment on the assurance that we can give in relation to our systems and the particular issue that was exposed and came to light in Betsy.
Deb, you want to start and then let Mark in add?
Thank you, Chair. Yeah, so we're aware of the issues that led to the error from Betsy, and we manage our inpatient waiting list in a very similar way when we're outsourcing patients into the private sector. So the provider code gets changed on the system to reflect that the intent is to take that patient to a different setting. We have checked ours because that was left out of the normal run at the month end and therefore not submitted. We've checked ours is very definitely in. So we don't have the same issue. And we keep a very close eye. So we scrutinise our numbers every month. We compare the submission this month to last month. So if there are any glaringly obvious anomalies, we pick them up. So, you know, there may be individual patient ones that we may not pick up on in that way, but anything big like that, we would see it automatically by way of those checks.
Thank you, Deb. Mark, do you want to add?
Yeah, I guess that provides the assurance that we're okay as it stands. We've got things covered, but we are looking to improve as well how we provide further validation of our waiting lists using AI on top of our digital clinical letters. So we're doing a proof of concept in neurology at the moment. So I'm going to roll out that specialties, but so.
You were sure, Jean? Yes, thank you. Pat, please come in.
Just reflecting on the narrative around the delivery unit. And I know you're doing a lot of work on this with colleagues at the moment at pace. But I would just urge that we do look very hard at our programme management capacity and capability as part of this. It sounds a bit counterintuitive if you think in savings and making recruitment, but we've got significant improvement programmes. You've got organising for success, PAN and Health Board, and this underpinning all of this is huge savings programme. And I just think failure is going to cost us a lot more. So I just will think about how do we need to strengthen our capacity and capability as part of that. And also then as part, coming back to us really, what are we going to do in the interim? Because the pace of delivery has to be such that I know it's going to take a while to fully embed a delivery unit, but what are we going to do in between to make sure we've got that support?
Yeah, thank you. So we are working at pace in terms of the scope and remit for the delivery unit, and I'm in discussions with the exec team. Tina's working very closely with me on it in terms of the scope, and we've got a programme manager in Organise for Success programme who's helping with some of this legwork. Next week I'll be able to share with independent members what that broadly looks like, and I'm having conversations with the exec team and with Welsh Government about how we accelerate that, because the Deloitte support we've had has been incredibly helpful in terms of understanding what's driving our underlying deficit and where the opportunities sit for us to deliver savings. And we are, as we will hear when we come to the finance, we are behind where we need to be in terms of execution of that. And we need to make sure we've continued the momentum. So I think there's a conversation that we started having about how Deloitte's stretching to the final period of the month, and that will be part of a rounded conversation about the support we need going forward. The other thing I think is helpful, the new managing director of performance and improvement, Chris Clayton, has been brought in to look at how the performance and improvement function works. I think there will be greater clarity when you're in a level of escalation around the support that organisations need. So Deloitte support's been really helpful to us, but that comes in for a period, and there is something about, we've acknowledged that this year was about building the foundations, and we've done a lot of that work. There's still more to do. Next year is really about transitioning to embed the types of things that we've described for performance management, programme management. And I don't disagree with you, Kat. We've looked at staff groups right across the organisation that are doing project and programme management. Some of them will need to stay where they're operating, but in principle, there's agreement that we would create a central pool so we can prioritise, make sure we're being consistent, but make sure people have got the right training. And I think there are different models where you bring people in from various different bits of the organisation, train them up and get them out again. But there are also really good models that we were just discussing where actually you work with other industry partners that might lend you people and they come and get some experience. So there are different options, and multi skills is what we need to have in that. So I think we've got some really good people operating across the organisation. They're not all necessarily in one place, and we're not necessarily using them as the engine room for our improvement and delivery. And that's what we're designing and going to create.
Thank you. And you make a really important point, Pat, because it's not just about servicing the programme, although we need the right capacity and capability for that. It's about governing as well. And we do have an example on our agenda today of how that's happening for the MATNEO improvement plan. But Tina, can I ask you to just add a little bit more detail around this whole capacity capability? Then I'll bring you on.
So just to pick on the two areas that we've talked about, the business intelligence and performance, and then the project and programme management, that's the two strands that we're prioritising the delivery unit and getting those. So to give you the size of the scale, we've got over 70 people with programme or project in their title in the organisation, and about 50 with performance information. So obviously we need to work that through to Abby's point of making sure that they're being pointed at the right priority areas, and that we've got the right capability, the skill set there. So that's, at least we know we've got that available resource in the organisation. It's how we organise that in the best way. We've got a plan on how we set up the delivery unit at pace by having some interim leaders until we then design what we need going forward. So I can bring a further update for the next meeting, and I can cover a bit later on the Organise for Success paper as well.
Thank you. Thank you very much, Tina. That would be helpful. Anne-Louise.
Thanks. Abby, you raised in your report the cancer pathway and the deterioration, whereas it had been going in the right direction. And I wonder if there's a timeline. I know in your report you refer to the pathology generally and what's happening there, but it seems I'm not sure what's changed between the months where we were just about hitting the target to 60% and it's gone down, whether that's the direction of travel and whether something can be done about it and what the timeline to do, because it must be disappointing for the staff and even more disappointing for patients.
Chair, I wonder whether you put that cover as part of the integrated performance report, because we're going to get focus on that, and there's a lot of really good work going on in relation to that. And Alison, just while we're on that topic, we've had HIW in looking at our some of our services relating to cancer yesterday, and it was a really positive inspection. Do you want to just one line on that, just so all members are aware?
Reviewing radiotherapy at Singleton for the past 2 days. And that's in relation to IRMA regulation, radiation ionizing regulations. And it was excellent feedback in terms of staff training, PADRs, regulation status, statutory, native Welsh language, patient experience, surveys relating to staff and staff wellbeing and engagement, surveys with patients and their experience from all of the professionals. And I think the main focus, and Richard joined the feedback session also, was on the multi-professional, multidisciplinary working that, and I think the innovation that they're undertaking, and also the advanced practice roles. So the multi-professional working and skill mix, excellent. Thank you.
Thank you very much. Thank you. Any final comments or points for Abby? Well, thank you, Abby. We'll receive your report and take assurance from our conversation. We note that for the board. We've got a single issue board on the 17th of February now around the regional cellular pathology solution, and then one on the 26th of February on the Simon transfer and an update on that. And we're bringing a comprehensive paperback on mental health, all aspects of mental health, to the March board. And Debbie will pick up the whole cancer services agenda in the integrated performance report. Thank you. Hazel, can we turn to you, please, for this?
Yeah, so this is part of a reset process we've had around creating a strategic risk register, corporate risk register, and then underpinning those and the operational risk register. There's further work to do looking at the operational risk registers, but now we've got the framework, the process right, reporting arrangements in terms of every board, and also through committees at the start of each agenda. What we're now going to do is start to really drill down and look at the articulation of the risk scoring, and look at the underpinning actions that have been taken, how they will affect the risk scoring as well. So we're really starting to drill those down. In terms of the strategic risk register, 17 risks there, 6 are at the board's risk appetite, 25 on the corporate risk register, and then operational risk register, as I said, we're doing a deep dive review on those now as well. So those are the main points I wanted to say, and just highlight that there is one new risk which relates to digital and the integration of a health record for mental health and primary care now on the corporate risk register as well.
Thank you. Thank you, Hazel. Nuria, would you like to come in?
I would. I think the first thing I would like to say is that at the Audit Committee, we scrutinise regularly the risk register. It's part of our systems of governance, and we need to take assurance that they're operating effectively. We had a very long discussion in the Audit Committee, and the first thing I would like to say is that we wanted to, on the record, thank Hazel and her team for the sterling work that they have done on the reset of the risk register. We really welcomed the improvements. However, there are still gaps in our assurance, and one of the challenges that we discussed with the Audit Committee was around the scoring of the impact element of the risks. For cerebral risks, the target is to reduce both likelihood and the impact scores. The narrative generally focuses on actions to reduce the likelihood, but they generally don't show how the impact of the risk is actually lessening as a result of that. We discussed many examples, and we've had the executive to actually look at those examples so they can provide some clarity. We also looked at some areas where we have pervasive and inherent risks in different ways to understand what the actual residual risk is, and more work needs to happen on that respect. We were concerned about the high level of operational risks that we're carrying as a health board, and we wanted to understand more the mitigating actors and again what the residual risk is around them, and we've asked for that work to be ongoing. We in particular wanted to highlight one risk, which is around histology, where there was significant concerns about patient harm, and wanted to find out what actions being taken. But on another note, what we wanted to emphasise to board members, because we really seek your support in this, is around the culture change that we need across the organisation to really grasp the opportunity the reset and the risk registers provide to really help us address that journey of improvement and to look at the behavioural changes that need to happen in line with our values and culture of this organisation. This is a real opportunity to have those real insightful conversations with our staff about how we can support them. That's all I want to say. I hope that sums it, but welcome any further comments from my fellow committee members.
Thank you. And we appreciate, Nura, the detailed, rigorous work that audit committee members undertake into the whole agenda of risk. I've got Nicola, then Tina.
Oh, thank you, Chair. I wanted to pick up risk 89, which is relating to the nursing levels in the prison. It's been on there for some time. Just wondering what we can be doing to support the staff that we currently have there at the moment, and are we doing anything to resolve the issues with the staff and levels there?
The answer to that is yes, Nicola, and it has been something that we've looked at to enhance currently what's there, but also to enhance support to those in HMP and working in that place, because it is an isolated place. So they are encouraged to access our wellbeing support. They undertake and are part of all of our kind of development programs as well. We will undertake, as we do with every service and every department, a full establishment review biannually. We're going to include them in that so that we can see where we are with those teams. I met the matron just the other day, and she was on our matron development programme, and she's really benefiting from having support of peers as well. So yeah, it is a risk that's on there, but I think that risk will reduce over the next few months.
And what I've done, Nicola, is sent to Jean as chair of QSD my correspondence with Sarah Murphy and Jane Hutt, because of course we get very little inclusion in our allocation formula for prison health. It's with the MOJ. So Jean, having asked me for this, now I'm minded to write again to Sarah Murphy, you know, as one of the issues they will need to hand over. So QSD, we could pick that up as well. That would be really helpful. Thank you. Tina.
Yes, just to say that we did discuss the workforce and OD related risks at the committee in December, and we've committed to reviewing those for the next meeting, which is in about 3 weeks' time. There is a recommendation in here to increase the staff health and wellbeing, because we're seeing sickness absence at the 8% mark now, so to increase that to a 16 score. But we also feel there's a need to review the scores for the leadership and culture as well, which will come back for the next meeting.
I think that's an important point, particularly for members of PSC who've raised this consistently. So I have Rena, then Steve.
Yeah, I just wanted to mention the risk in relation to population health and the, if you like, the controls that are viewed as being unsatisfactory in terms of the way in which we've, as an organisation across the piece, embracing this whole agenda of population health. And I think it's very strongly links to obviously the role of the new Population Health Committee. And I'm quite concerned that we need to get, if you like, defined actions in place as opposed to just the strategy which we have. But we need more specific actions and time-related actions over a period to get that embedded within the organisation. And I don't think we're there with that yet.
I'll ask Marie to come in on that, Rena, before I bring you in, Steve, because presumably, Marie, this features in the annual plan for 26-27, those specific actions.
Absolutely, and we will have those broken down into very detailed and time-related action plans. So that's what we're working through at the moment. So you can expect that coming back through that process.
We look out for that, Rena, coming through the annual plan. Steve, then Richard T. Steve.
Yeah, thank you. And mine is relating to the WICIS risk 108. So I guess, Matt, this is for you. In mental health and learning disabilities, we're rolling out the RIO system currently. Does that not deal with this issue, at least as far as that service group is concerned?
It certainly does, Steve, to a point. And this risk has been building on its way to the risk register for a couple of months. And in the meantime, we've had some really good news, haven't we, in terms of the funding for RIO. I think until we are live and until it's established, we still have that risk, don't we? There is still the possibility of a lack of information that could play out this. So
So hopefully, I think it's later this year that should be fully implemented, and then this risk will dissipate. I would hope.
most of the services will be live by the end of March, and then the integrated teams by October.
Okay, great, thank you.
Richard and then Jean. Richard.
Getting back to the population health conversation. So the population health team have developed the population health state of the population report. So we're raising the awareness of that internally. We covered that at a couple of big meetings. It's also one of those building blocks as well for the clinical engagement around the clinical services strategic plan over the next few months. So it really will be embedded into everything that we do going forwards.
And we will take an item in the March board on the work that Jill, Hugo and team have been doing on population health, because that's a fitting way, because Jill leaves us at the end of March. So it's a fitting testament as she leaves us to all that work. Well, Jean.
Coming back, if I may, Chair, on the illustration of Rio. Is there, and this is something that we could take into the digital committee, because there are so many programs going on in terms of dashboard development, Rio implementation, might it be opportune to refer to Digital Data Research and Innovation Committee to build a picture for us across the organisation of where we are, particularly at risk of falling foul of legislative or statutory information?
Yeah.
I refer to clinical coding, etc. in that.
That's an interesting point, Jean, because Welsh Government is asking, and Nuri and I are both audit committee chairs. I chair the audit committee for Amgueddfa Cymru, and we've just had a swathe of documentation from public bodies and public bodies unit that is falling foul of legislation, lack of compliance. That is one issue that we've been asked to pick up on. So certainly, can we refer that to Andrew, to your committee? Really important point to you. Thank you. Any other points there? So obviously, Hazel, we welcome all the work that you and your team are doing, as Nuri said, support all the work that audit has underway and the recommendations coming out from audit. Got an action on prison health to take that forward. We've got an action on leadership and culture and looking at the score around that. And we'll have an item on our March board around population health. We'll pick up other issues as Rena's raised in the annual plan. And we're going to refer to DDRI, this whole question of picking up all schemes and systems we have and compliance with legislation. Have I covered everything? Okay, thank you very much. And thank you again, Hazel, for all the work of your team. So I mentioned earlier then that we always have either a patient or staff story, because it's important that the board, remind ourselves of why we're actually here, in the interest of patients and the well-being and support of our staff. And we do have a patient story today that links with the very important items we have on the agenda around perinatal services. So Liz, handing over to you.
Thank you, Chair. And it did seem quite opportune to bring this particular patient story today for the reasons that we've just discussed. The individual lady that's going to tell her and her partner's story, I think will show the ongoing feedback and engagement that we're seeking from women and families as they go through our services. So I will leave you to hear the story and then take any questions following.
This pregnancy was so different from my first when I had my little girl. For one, I was diagnosed with gestational diabetes. I had an absolutely brilliant diabetes midwife who gave me lots of phone calls and checkups, and I also had regular scans. Additionally, I was also seen in the antenatal assessment unit a few times. I had my first admission there when I was 27 weeks and I'd experienced some bleeding. And when I rang, they were really nice on the phone and they just let me explain what I was worried about and said for me to just come in and get checked out. So I went in And I was actually only waiting in the waiting area for, it must have been less than 5 minutes when they came and then took me to a private room. When we were there, they checked me over. They also did a quick check of baby's heartbeat. And they were just really reassuring and explained that they'd be moving me to the 4-bedded bay that they had to do a longer check on baby's heartbeat with the monitor. The midwife was so helpful. So when they were putting the monitor on to check baby's heartbeat, she explained everything. And I really felt like she gave me the opportunity to ask questions. The monitoring only actually took 10 minutes, and then they told me that a doctor would come and see me. And it wasn't too long before that happened, and the doctor performed some additional checks, and they were really happy with everything. So they were able to just reassure me and my partner that everything was okay, and if we were worried or if anything happened again, we could call and go back. When I looked at my notes when I got home, I could see that there was this paperwork with different colours on a chart, and I could see that they'd actually categorised how urgently I needed to be seen. Then the second time I was actually seen in the assessment unit was when I was 34 weeks and 6 days pregnant, and it was for bleeding again, but I was a little bit more worried because I wasn't sure if my waters had gone. And I also felt like my baby wasn't moving as much as normal. This time when I went in, they actually just took me straight to the bay area and they put me on the monitor and they checked me over there and then. And I found the doctor came very quickly to see me. I had a few checks and they confirmed that my waters had gone. So the doctor gave me some information about steroids and the next step because it was looking like I might have my baby early. I thought the doctor was really good. So he gave me a lot of verbal information on the benefits and also the risks of maybe having steroids. They also gave me a leaflet as well, and they sort of said, oh, we've told you a lot, but here's a leaflet and you can also ask us anything. So I felt like they told me everything I needed to know and that the information was really balanced. And when it came to the decision of whether or not we wanted to have steroids, we felt really supported and not under any pressure. So the doctor actually gave us space to make that decision. In the end, we actually, when we looked through the leaflet and thought about what the doctor said, we decided not to have the steroids. And when we told the midwife, she was really respectful of our decision. And I just felt like none of the staff questioned us. The midwife told the doctor, and we felt really supported with making that choice. My partner was allowed to stay with me the whole time. That was really nice. I just found the staff so responsive, so they took what I was saying seriously and they were so quick to provide checks in response to what was happening. I got admitted to the antenatal ward and had my baby boy the next day. I just had incredible care from when I first set foot into the antenatal assessment unit to the antenatal ward, labour ward, theatre, and also in the neonatal unit. They were unreal. There are just so many members of staff who made such a difference to our experience, and we are so grateful to everyone who supported us on our journey to having our precious little boy.
So I think the story that we've heard is through all parts of our pathway, but when she's talking about antenatal assessment, she means our triage unit and the point of access that is there for any women who have any concerns or worries. And we'll come to more detail around that a little bit later. It's in our perinatal committee report, but also in our perinatal improvement programme. She really wanted to come and tell us the story, and she did that for us in between Christmas and New Year's because she just felt that her experience was a good one. We want that standard for all of our women and babies, but it's testament to the whole of the pathway. And how we picked up this story was, you'll hear also later about our piloting the All Wales questionnaire, which picks up every part of a pathway. And she was part of that feedback, and then we got in contact and she gave us her story.
Thank you, Liz, and that's a very good segue into our perinatal committee section later. Any comments or questions? Teresa?
Thank you very much, Jen. It's nice to see the video, but I was also wondering if we managed to see similar feedback from people who haven't had quite a positive experience, and if we do share that at the board meetings as well.
That's a very important point, Teresa. Liz?
Yes, as I say, the processes that we now got in place give us opportunity to intervene if anybody gives any poor or very poor feedback, and we review those daily. So we can usually contact the women or families, but it'll also be part of our ongoing engagement, which you'll hear about later, Teresa, as well. So a huge amount to be able to hear the experiences, good, bad, or indifferent.
Jane?
Just building on that point, is it worth mentioning, Liz, the presentation we had, the presentation day, when there certainly was a sharing of the not so good as well as the good?
Yeah, we did have a learning event in November where we had women and families telling their stories, and those that had been harmed also telling their stories. So it was really poignant. They were very generous with their time and sharing their experiences. A lot of the learning that we've had is through that process, and it will continue in that way.
Okay, and we'll hear a lot more about this whole triage system not this afternoon, anytime after planning and planning and partnerships committee. Thank you. So we move then into setting strategic direction, and we will send our thanks to Sadie and her partner for sharing that with us, and send them all our best wishes. So Steve, take us through any key matters from Population Health Group.
Yeah, thank you, Chair. So we met last on the 4th of December, the Population Health Committee. There are three matters that the committee wanted to alert the board about, and I'll invite Hugo, who's here for Jill, to comment after I've gone through them briefly. The first was on the inequalities in premature mortality from cardiovascular disease. In Swansea Bay, we have a much higher mortality rate, twice as high as some places in the UK, and it is rising. Early detection is key, and undiagnosed hypertension is one of the main problems. It used to be something that GPs dealt with in their contracts, but that has changed. So the public health team will be looking for support to develop a pharmacy or community-based screening program by invitation, and that will be subject, obviously, to funding being made available. The second alert is to smoking cessation service. You'll all be aware that smoking is the most significant preventable risk across a multitude of diseases. We know that inpatient cessation services work. So when people are in our hospital, we help them give up smoking, and that works. But it's funded on a short-term basis always, and we need a stable long-term funding basis to make that service effective or more effective. And the third issue was lung cancer screening. We had Chris Coslett came to talk to us. He's the Lung Health Check project manager for Public Health Wales. Lung cancer is the leading cancer death in our region. It's very often diagnosed late, far too late for any effective treatment to be, or any treatment to be effective. And so the proposal from Welsh Government is, or for Public Health Wales, is that there should be a screening process in place for 55 to 75-year-olds on an invitation basis. These are sort of ever smokers, they're referred to, this group. It will be funding dependent, but is expected to come in late 27 and late 28. So three big hitting reports that came to the last committee. I'll ask Hugo to come in, but what I think the committee would like to hear as a consequence of these alerts is that these issues will be picked up in our, and Marie's going to come on in the next section to talk about clinical services plan and lots of other plans, but these things get picked up in our planning, either at health board level or at GP cluster level, because these are areas where we can do quite a lot of very good work to mitigate these issues. So I'll stop there, but Hugo, do come in.
You come in, Hugo, and then I know Abby wants to come in as well. Hugo.
Well, thank you. I think you've outlined things very clearly. The screening for lung cancer is an exciting development across Wales, and I think will save a significant number of lives. I think we have a strong smoking cessation service, which is very much embedded in the services across health board. Cardiovascular risk is a huge problem across Wales and has been for decades. It's very deeply ingrained. And I do think, as you say, primary care is key to maximising the opportunity to prevent cardiovascular disease. Thank you.
Abby, I know.
Thank you. 2 comments. In relation to lung cancer, it is really good news, and we will be able to pick up those cases. Clearly, some of those cases will benefit from surgery, which would not have been available to them in terms of late presentation. So modelling that in terms of what that would mean in terms of impact of the treatment, the surgical intervention that we would be able to offer patients as a result of that will be really important. And as part of our thoracic service, coming back to cardiovascular disease, Jill's report, when it comes through, or the team's report, I know it's a team effort, is really hard hitting to see the fact that our communities are amongst the most disadvantaged in terms of poor cardiovascular disease outcome. It's really difficult to read. We're in the top 10, I think, for Swansea. Swansea is out of all counties in England and Wales. So it's a really urgent issue if you think about our commitment to addressing health inequities. We've got some really good research that's undertaken by Swansea University looking at the treatment gap. So patients who should be being identified through routine mechanisms and being started on what are actually cheap and frequently used medications that would reduce those risks. And that treatment gap is a real health inequity playing out at large, because the patients who most need to be on these medications are the most likely to be those that are not. And so that's what we call the treatment gap. And we need to work out how you address that treatment gap. And Steve's right to point out changes to the GMS contrast. You could argue this should be core GMS business, but we know that in the way that GP practices are operating, that they need more support to be able to identify those patients, and then we can apply treatment and wraparound support, ensuring compliance within a programme of drug therapeutic intervention. So I'm really keen. We've had a discussion with Cardiff, I said that before, Swansea University, been doing some brilliant work in this space, using the SAIL database. And we met with Howard, our colleagues, a couple of times now with them about how we might move what was a particular intervention and research into a more targeted and bespoke piece of work that would have benefit very quickly in terms of reduced stroke and reduced MI events in our population. Not big numbers, but actually significant numbers. And we're really keen to work that through. It would be part of a value proposition as part of the value-based healthcare. So when we've got a little bit more on that, Chair, we can bring that back for colleagues. We'll need to bring it back as part of our plan, because I'm also acutely aware that we've got a zero investment context in which we're operating our plan and direction in Welsh Government. So I think if it can come through the research approach, I think that would be really helpful, and through our community by design programme and the enhancements we've had in the allocation for primary care, that would be really helpful. Thank you.
I have Marie, Darren, Rina, then Marie.
Yeah, I was just going to acknowledge really that one of our kind of eternal conundrums is how do we invest in our barn door obvious, prevention, be it primary or secondary prevention services, so that we can get ahead of those diseases as they develop in our communities. And building what Abby's just said, one of the pieces of work that we're picking up through the Regional Joint Committee portfolio is the STAR project, which we are doing on diabetes, where we're looking at how we can allocate resources in a more appropriate way within our existing financial envelope to try and actually develop some scalable solutions so that we can bring prevention into the pathway in a more timely way. So that's a very specific methodology that we're trialling with partners to look at how we can bring that systematic approach into the way that we can build a programme around this without having to seek additional funding. So it's early days, but an approach that we're hoping to scale up if we can make that work.
Very much, that sounds exciting. Darren, do come in.
Thank you, Chair. I'm going to make 2 points. One was the value allocated point that's been made, so I want to repeat that. And the second thing is we had a discussion at finance directors last week about the range of non-recurrent money that comes into systems, often without the knowledge of the NHS Wales finance director through policy leads. And we're going to take a new piece of work just to look at what those range of issues are, because they're causing uncertainty. They're often in very important areas that have developed them well, and we will pick this up as part of that wider piece of the work.
Of course, that would be important, won't it, for our planning, just looking what is in that envelope of resource coming in. Thank you, Darren. Rena, please come in.
Yeah, I just wanted to draw members' attention to the point 4 about weight management and in particular children's weight, because I think this is a really important issue for us. It's one of our objectives, isn't it, to give children the best start. And if children are obese, often they end up as obese as adults, and then you end up with all of the conditions that we've just been talking about, one of which could be cardiovascular. So the reality being, I just think how important this is for us, and that we must have in our sight that this has got to be one of our key things that we want in our strategic plan. Because I just think it's a no-brainer in terms of being able to, if you like, get that start right for people in our community. Thanks.
And at the RJC, we did have a long discussion on food and access to healthy food. So that will play in, when we get the papers from that, and also play into our annual planning as well. But we'll circulate the debate and the presentation we had on food linked with the Future Generations Commissioner's Office, because he's made that one of his key aims as well. That's great, thank you. And Louise.
Thanks. I know January was the Health Board's Wellbeing Month, and I wondered whether there had been an opportunity for staff to have heart health checks and what the take-up was, and whether, as in there are in Japanese industry, there are regular checks for staff so that we can keep an eye on staff. After all, they are a huge part of our community, and then they go home and can say the same thing.
Tina,
come back to that. So we have offered a health screening for staff, and that's been publicised across the organisation. I haven't got the take-up rate yet, but I'll commit to bringing that back for the next meeting.
Or you could send it around outside the meeting, Tina. Thank you, that information. Thank you very much, Anne-Louise. Nuria.
I think Marika's covered what I was going to say in terms of that better resource mapping that is really important for this agenda. But I also urge us to look at the balance between those clinical interventions and the prevention to address over-treatment, because I think that's really important too, and we really need to think about that in terms of improving our population health outcomes. So not just about our partnerships, but actually what is within our control too. I think that for me, the difference in equitable access in relation to lung cancer and cardiovascular was really significant, and there's more that we can do at that front too. So I think it's in that planning phase. I think that there is potential for us to think about ourselves as well as what we do with our partners. I think Rena picked up the point about healthy weight, which was something that I was going to raise.
Thank you. So Marie, you'll be gathering all these different points and making sure that where we can, we prioritise, but we include in the annual planning process. Because we will have to make decisions and choices on what investment we have. And it's interesting to know there's an envelope of non-recurrent monies comes out from Welsh Government, won't we? But we'll pick that up. And Steve, thanks to you and the committee for the alerts and for your work on that. And as I say, we will have a major piece on population health at the March meeting. Thank you. So Marie, as I said at the beginning, this is now an established part of the board agenda, and it gets richer in information and intelligence every month. So if you can take it that we've all read it, yes, and if you can highlight from the board those things you really wanted to know, but perhaps if you could stop as well at each point that the board needs to make a decision or take some action, please. Thank you.
Thank you, Jan. So because of the nature of this portfolio, a lot of this information is for updating boards. So in terms of decision making, a lot of that sits in other parts of our agenda. But So I will just very quickly run you through the key areas of the report. So we have an update at the beginning on our strategy and strategic programme development, so that you'll see within that section, we've given you an update on where we are with the development of the clinical services strategic plan, which we need to call something else, but that's a real mouthful. I think there's really good progress in this area, despite the fact that we have had lots of our key stakeholders with all hands on deck at the operational grindstone, as it were, over the last month or so. We will be going out to wider engagement during January and March. That's largely internal to ensure that we've got good clinical input and oversight in terms of the process, where we've got to, and to check that we've got the support and endorsement of our key internal stakeholders before we go out to wider engagement with our communities and public after the election process has been concluded. Good work, as I say, going on in this space. If any colleagues would like to access some of the working documents as we are developing them, we'd be very happy to share them. It's really important that we get this right. Previous discussion that we've just had highlights the fact that we have to do more in the space of prevention and improving population health. That is a cornerstone of our clinical services strategic plan. Absolutely has to be focusing on how we can get ahead of some of those priorities, and also an opportunity for us to check that we are clearly aligned with not just our own organisation strategy, which kind of goes without saying, but national policy. And we know that since changing for the future, which was the preceding programme, much of which is still extant, some of which isn't, we know that there will be, in terms of service provision, a stronger emphasis on looking at how we work more collaboratively across broader regional partnerships for some of our more specialised services in the longer term. So that's kind of the other end of the spectrum, where we need to make sure we've got some real clarity coming out of that process. So good progress. The annual plan, I'll come on to now. So we have taken quite a different approach this year for the reasons that we will discuss further in the meeting around our sustainability from both a finance, workforce and clinical perspective. We know we have huge challenges, and we have ensured that our annual planning process this year is focused on ensuring that we have a collective leadership approach to addressing those challenges, and also recognising that we're not starting from scratch. We are building on a suite of programmes, sustainability programmes, that we need to accelerate and amplify into next year. So it's not a standing start, but we know that we have to strengthen and improve delivery in a number of those areas. So I won't go into the detail at this point, but I'm happy to take questions on both the process and the content. The NHS planning framework overview is provided as part of the report to ensure board colleagues are cited on our the requirements of Welsh Government to ensure that we comply with the direction and directives that are provided at national level. And we've got a high level timeline there to articulate the kind of key touchstone points that we are using to kind of gateway assess our approach to conclude a final draft of the plan that will come to board at the end of March. You will of course see a high level draft in our board development session in February. In terms of the planning, the partnership agenda, you'll be aware that we have a wide range of partnerships that we report from a governance perspective through audit committee, but the material kind of decisions and updates are provided in this report. So there's an update there on the RPV programme. We have, through the RPV, refocused and aligned the three key programmes that we're driving forward through the RPV in our December meeting, and confirmed that those will focus on how we strengthen our partnership working to support communities and older people, how we work together to have a more focused commissioning approach, and the mental health transformation being the third one. There's more detail there on some of the individual work streams. PSBs, again, lots of work in that space, and particularly focusing on how we are working together to deliver on the recommendations of the Future Generations Commissioner recommendations. There's further detail then in our commissioning arrangements, which I won't go into because there is quite a lot of detail in there, but I'm happy to take any questions on any of those. In terms of formal endorsement, the only thing that we are asked to formally endorse, and I skipped over sustainability and climate change. Really good work going on in that team, that's being recognised nationally as well. So I would like to commend the efforts of our sustainability and climate change team, because they are really leading the way. So we're being asked to endorse the climate change risk and opportunity assessment, and also from an EPRR point of view, emergency planning and preparedness. One of the things that we have to do just to tick the box to ensure that the board have had oversight is to approve our severe weather procedure, which was attached as an appendix to the EPRR update. So I think that is a very quick canter through. It was a very busy document.
So any questions? Jean, then Rena, then Anne-Louise.
Thanks, Marie. As always, very clear explanation of everything that you're doing. I think it makes more sense to us now, so thank you for that. We have 3 questions, if I may. So shall I go to all 3 first?
Yep.
Well, it's page 8, and I know we're going to discuss community by design in the future meeting. But in terms of the narrative, it mentions, your narrative mentions the proposal to establish a local community by design transformation group. And whilst we need clear focus on those initiatives, is it always the answer to set up yet another group? Can't we work to keep things simple? Because I note that there was a steering group established in April 25. That's my first question. The second one is page 15, where you refer to the Health Board now assuming responsibility for clinical services within the criminal justice system. Got my teeth in it, from April the 1st this year.
Yeah.
But given we are reviewing local resourcing challenges, can we be confident that our current evaluation includes this impending change? And I note that the finance implications are being considered. Thank you, Jan, for sending me the information where you had written to both the Cabinet Secretary and one of his ministers. However, I do note that you've had no response to that inquiry, which correlates to my question too. So I would ask if we could follow that up, because it's been outstanding since 24. My last question, Marie, is the National Complex Care Database. It's just for my clarification, because reading the narrative, it came across to me as slightly ambiguous. Are we saying that there's a suggestion that the national database will be replaced by individual health board databases?
Sorry, what page was that, Jean?
That was page 16.
Before you respond, Rena and Louise, are your questions related to these 3 points, or are they different? Different, okay. So Marie, come back to Jean's 3 points then.
I can indeed. So very good challenge on the steering group for the community by design. So we are still discussing how we can best develop a plan for delivering against the very specific requirements that Welsh Government have set for the community by design programme. I think it would be fair to say that there is quite a lot of very explicit direction coming from Welsh Government departments around how we need to strengthen the delivery of services, both in primary care and in our wider kind of community services, working in partnership with all of our other wider stakeholders. And there are a number of programmes that overlap that are being directly mandated by Welsh Government. One of the things we're doing at the moment between ops and planning is having a look at, and we're doing this nationally, so we're having this conversation at Directors of Planning on Friday next week, because we are very conscious that we could just set up a bureaucratic jungle of steering groups that aren't going to get us where we need to go. So one of the pieces of work that we're doing with our PB colleagues is looking at how can we kill 3 birds with 1 stone if possible. That said, it is really important to note that many of the priorities articulated through the Community by Design programme relate to how we improve pathways between primary and secondary care. So it's very specifically about clinical service and pathway improvement between health services. So again, we just need to make sure we don't lose that by trying to create a kind of, you know, one size fits all kind of governance structure. So, but it is important, and we'll bring that back as that develops.
Marie,
Your second-
just come in on that point before you move on.
Just on that point, June, you picked up, we've had a steering group for a while in the community bed design space. What we don't want to do is put overkill on top of it. So it's a requirement that we put a board structure above it, which we will do. But the steering group is working very well for us, and we've had really good feedback from the national group at the moment, and they're looking at replicating our model elsewhere. So we will build on that. We don't want overkill on, we just make sure we do what we've been asked to do. But it's working quite well at the moment, and as Marie, we've got clear priorities that we were already working on.
And then the area planning board update around the health board picking up a more of a leadership approach around the delivery of services that are currently sitting in the criminal justice system. We haven't at this point agreed to that. So there is still work that is ongoing through the area planning board transformation programme to look at how that service model can be effectively developed, so it doesn't become a very heavily health delivered service, but has appropriate health clinical governance and oversight to make sure that it's safe and appropriate, but is also affordable within the envelope that's available. So we at this stage have not agreed or signed anything off to take that on, and we have asked the area planning board to confirm interim arrangements are put in place until that becomes an agreed way forward. So I think we would want, as a clinical partner, to ensure that there's appropriate governance and oversight, but it is a multi-agency service responsibility that we need to ensure retains the appropriate engagement of all partners, but recognising that health does have a lead role in that space. So we that's work in progress. Not without its challenges, as you can imagine, for the reasons that you alluded to. And then the NCCD, that will continue this year. So that is a database that we will continue to use from a health perspective, and until there is an appropriate alternative. So there's still conversations going on with JCC, who are shared services, and JCC, who are currently leading in the arena, but we will continue to engage to ensure we have an appropriate alternative.
Thank you.
Rena.
Three areas really. The first one was the state of the population report. We haven't seen it as independent members, so I just wondered.
Happy to share.
Yeah, can we have it
It's
circulate?
going to come in March as a specific item.
Right,
but I think
we
will
it is available.
circulate beforehand.
Yeah, okay. On the continuing healthcare side, are we anywhere nearer to joint funding? I just feel as if we've been talking about this probably for 20 years. Whereas they were talking about it when I was working in local authority, which was over 16 years ago. So in a way, I do feel, I mean, we heard at Performance and Finance that there'd been some good progress made in terms of the funding for looked after children in that space. So I just wondered your view on, are we much nearer? And the last thing was, because I'm on the Sustainability and Climate Change group within the Health Board, I really do feel this group has got a lot to offer, both in terms of sustainability on carbon reduction, but also in terms of finance, because a lot of these things actually produce savings for us. You know, you've only got to look at the solar panels that we've got up at Morriston and how much they're contributing in terms of reducing our energy bills. You know, so there are obvious things that we can do in that space that I really think we should embrace in terms of encouraging, and I suppose in terms of our plans for the future, making sure that those sorts of things are embedded in our plan.
Thanks.
Yes, so population state of the nation, I will send that round to colleagues to have a look at in advance of our next meeting. In terms of CHC and joint budget, it is a bit of a holy grail. It is a bit of a minefield, and so continuing healthcare in its purest sense is an NHS only commission service. And actually what we mean when we talk about joint funding for CHC is that much broader complex care or ongoing care commissioning that we have a joint responsibility for. And that joint responsibility is the bit that's very difficult to determine. And there are different arrangements that are in place for different types of service and between local authority areas and even within health board services. So it is a complex arena. It is something that I genuinely believe we will only resolve through having a joint budget with our partners ultimately. Our ambition is to try and get there by the end of this year, to have a proposition for how we do that. So I now chair a regional commissioning programme board in the RPB arena, and that is one of our ultimate goals, is to get to a point where we can have a joint approach to commissioning, ultimately with joint budgets, but we have a stepped process that we need to go through to get there. It's another one of those where we have an NHS CHC programme, and then there's a separate national government local authority CHC programme. We need to join it together at the highest level in a way that is more meaningful. We think we have big CHC cost pressures. If you look at what that looks like from a local government point of view, our figures look small by comparison. But we all know that we're only going to be able to commission the best and most appropriate care if we do it together. So there's a recognition that that's the case. I think the financial drivers and need to deliver savings can undermine that. And one of the ways that we're trying to address that is by doing the work that we are doing now on right sizing and repatriating, to do that through a joint approach and very transparently in that regional commissioning programme. So that's where we aim to get to. We've got some baby steps to take before we get there, but I think we've now got the structure. It's important that we maintain relationships and we maintain all of that softer stuff, as well as having a good process and good governance around it. But that's what we're aiming to do. And the sustainability observation, I completely share your view. We've got a brilliant team. Really, they've come up with some great stuff. They've come up with the paper tourniquet and the reducing our disposables, and they've made some significant inroads into that. I would love to be able to amplify the work that they're doing, and one of the things we'll be looking at as we reorganise the way that we look at how we target our resources on a more allocative basis, to look at how we can bring some of those principles and bring some of our teams together to do that on a more structured basis. But I agree, for such a small team, they punch well above their weight.
I've got Anna-Louise, then Richard T. Anna-Louise.
Thanks. My question was also about CHC and joint funding, but also models, and whether there is a model in any of the devolved nations for the direct payments that we can base ours on.
So there are. So direct payments has been in the system in England for some years. The information and advice we've had from English colleagues has been this needs to be done on a stepped basis, and it takes a while to build up the support that's required to do it. A lot of it's contracted out in England. One of the things we're trying to do locally is work with our local authority colleagues who obviously already have this in place, to try and see whether or not there's an opportunity to kind of piggyback on their systems and work to develop an integrated approach from the start. There's a lot we don't know at this point. We do know that Welsh Government have given a commitment to implement from April, so we recognise that we've got to get on with it. We've got a bit of a challenge in that the guidance won't be available until April, so we're trying to work very closely with policy leads at Welsh Government level. So they're coming to speak to us regularly, both formally through our CHC programme meetings and independently as well, to give us sort of advice and support. So it is still a lot of work in progress with a very few number of people, both nationally and locally, able to devote time to it. But we will, by hook or by crook, we will.
And I saw that you're bringing it back to the March meeting. Yeah. Presumably that's because it's all systems go by then.
It will be.
Yeah, thanks.
Richard.
Just coming back to the amplification on the climate change, I think there's a lot of good work that's going on there, and as Marie said, staff are passionate about it as well, but it does also offer us the potential to save money. And the next iteration of the Making Every Pound Count campaign does feature an example of that, and we're constantly on the lookout for other examples as well. The next example is around the efficient and effective disposal of waste, which does have the potential to save quite a lot of money across the health board. So a good sort of sweet spot story there.
Teresa, last point to you.
Yeah, so just for me to understand, well, I'm keen to understand which of the partnership programs will be capable of reducing some of the pressures we experience and potentially delivering some benefits and mitigating some of the risks that we are facing across the organisation in like the short term.
So all of them really. So there's quite a wide range of partnership at the most strategic level with our partnership service boards, which is with our local authorities. And then we have a regional partnership board where we are working with predominantly social services and voluntary sector colleagues to look at how, by working more closely together, we can provide better support for our citizens in the community, work better together to make sure that our pathways where we're working together are more effective, and also to provide better support for our citizens when they're coming out of some of our services. So all of our partnerships have an underpinning mandate, if you like, to look at how can we work together to make sure that our services are delivered in the right place by the right people at the right time. I think it would be fair to say that that landscape has become very busy. So I think one of our big challenges is, as successive kind of policy leads have layered on more ideas, more requirements across all partners, it's made that quite a complex piece. So if you look at the partnerships tracker that we've set up, for example, that goes to audit committee, it lists all the partnerships, who's on what its purpose is. And I'm happy to share that with you if you like, just as a kind of simple overview of what is quite a complex landscape. But that is a very good question. Thank you.
And Teresa, I'm sure Nouria and Marie would be happy to give you a briefing outside the meeting, because this is such a complex agenda. Thank you. Thank you as ever, Marie. So we've called this to a conclusion. So we consider, and obviously we support all the work we have underway with our partnership with RPB and PSD level. We obviously need to be aware of the implications of both direct payments to PHC and taking over services in the APB arena. And I think the PFC already has a remit to think about direct payments for CHC, do you? Or if
We have done it, haven't we? We have had reports.
Yeah, okay. So could you pick up those, we'll remit both of those two. And then taking over APB services and direct payments, PFC. And then we're asked to endorse our climate change risk and opportunity assessment and be aware of further work on that. We're happy to do that. And then are we happy to approve our severe weather procedure? Thank you. And as ever, please convey our thanks to your small but perfectly formed team when they put all this together.
Thank you.
Thank you. So now delighted to welcome to join us. We've got Patty Greaves, Clinical Director of Midwifery, Leon Green, Programme Lead for Corporate Nursing and Patient Experience, and we have Naja Ali online, I hope, Clinical Lead for Obstetrics. So Naja, we know that you're in clinic and you're dipping in and out. So Caris will let us know. Is she there?
Not able to join at the moment.
She's not at the minute. Okay, hopefully she will be able to join us. So I said at the beginning, this is a milestone meeting for the board. If we think back to July 2025, when we took, the final finished report from the oversight panel and the independent review, and we look at these papers now, and we just see how far we've come. And I think for me, the perinatal committee report is outstanding. I just say that, and the way it's developed, and congratulations to all of you. And then we're at the point now where hopefully final plan we can send on to the oversight plan. So before we even start, I just hope that you'll be very proud of yourself and all the team with you. This has been a hard slog, it's been traumatic, it's taken such a lot out of you all, and look how you've come through. Congratulations, before we even start. So I'm going to hand over to you then at this point. So who's beginning? Liz.
Thanks, Jan. Yeah, I'll start. And apologies from Sue Joy and Madhu. They are both on annual leave, and everything that we've achieved has been through a whole multidisciplinary approach. So first of all, I'm going to take you through the regular perinatal committee report that comes to our board now through Quality and Safety Committee. I won't go into huge detail, but we're very happy to take any questions. But I just wanted to outline the breadth of measures that we are now looking at as a perinatal committee. Anne-Louise is the board champion for maternity, as am I, and we are both members of the perinatal committee. We will develop that programme further from a board champion perspective and make ourselves known to the service and to those that are utilising the service. But the perinatal committee report outlines all of those indicators. So we had 238 women who birthed with us in November and 249 babies born. So again, some multiple births there. We have really outlined our C-section rates, and we know that our C-section rate is rising, and we know that that is a national trend, and we are tracking that as best we can with the rest of the UK. And in some areas of the UK, C-section rates have increased to overtake more vaginal births. So we're particularly focused on enabling our women to make informed decisions when they choose to have C-section, and we also have set up a group to ensure that we provide a really comprehensive and balanced information to ensure a fully formed decision is made. We've put our infection rates in there for maternity, and we've particularly highlighted that most of the infections that we see are from community samples. We're working with our community midwives because we want them to be involved in the collection and understanding of those infections particularly. And if you cast your mind back to that November the 19th event, we heard from one of our women who had been particularly affected in the 28 days post-partum around infection rate. And whilst reporting for those infections has now reduced to 14 days after birth as a mandated reporting period, we're still monitoring those 28 days because those women are still in our care and we want to have input and understanding into the care that they need. The neonatal mortality and morbidity is outlined there, and I think we're all learning how Embrace works and how we can monitor even before Embrace reports, because the reporting is usually 2 years behind. We're very clear about the investigation, the learning and the understanding of any mortality or morbidity in our service. All of the rates are there. What we've tried to do is really benchmark. If that benchmark is not available to us on an all Wales basis, we're looking at the UK maternity database and using Embrace in the past. We have reported our stillbirths in here as well. Everyone is tragic. Everyone is investigated, some internally, some externally. Our rates are currently in line with UK average for the size of units that we are, but we don't underestimate the care and compassion that those women need and are given during and post. Neonatal deaths are also outlined in there. They are all Embrace report. Well, they're Embrace reported if they meet certain criteria. Some of ours are Embrace reported, some were preterm and therefore not reportable to Embrace. By that, I mean less than 24 weeks and probably at the edge of viability. We've learnt a lot, I know, about hypoxic ischemic encephalopathy, and we report our rates in there. We have looked at that on a 12-month rolling process because of the low numbers that we have and the number of births that we have. But we have seen a 45% decrease since its peak in April 24, and we know that's a significant part of the independent review. Triage we'll talk about a lot more in the improvement programme, but we are using the Birmingham symptom-specific obstetric triage system, which is a standard system used across the UK. That gives us an ability to monitor how we respond, and our story this morning talks about the time it took to have that response. So we outline all of those metrics, and as I say, at Quality and Safety we go through in much more detail. It's been up and running now in November for a year, and we've seen 4,426 women through that process. It gives us the ability to really monitor how we respond to those who need us through the emergency pathway of antenatal and postnatal. We've brought in this time 3rd and 4th degree tears as well. That is a standard that is looked at across the UK. And we know for us at Swansea Bay, our standard, when we look at the maternity stats for NHS England, because we don't have these stats in Wales, for a unit our size, our percentage is lower, although each one of those is investigated and we look to learn. We are going to look at modality of birth as well, so that we can even further distinguish anything that really impacts on care in birth. We outline postpartum hemorrhage as well, and we have seen a reduction in postpartum hemorrhage. These are all reportable as NRIs as well. So, you know, most of these indicators we do report into Welsh Government. We've outlined the incident reporting and the details and the categories. Patient feedback and experience is outlined. I really want to commend our midwife who has come to work specifically with us on engagement. The work that she's now taking forward, the communities that she's able to reach and help us with our further engagement plan is really paying dividends. We look at induction of labour and delays to induction of labour. We now monitor that. We report every delay over 24 hours, and then we triangulate any harm. We haven't reported harm from an IOL in some time, but we will continue to monitor that. Our workforce metrics are there. We have successfully recruited into our midwifery vacancies, our neonatal vacancies, and into our obstetric and neonatal consultant posts. There have been some gaps, but the service themselves has re-looked at their rosters in consultant posts and have covered those gaps with no detrimental effect to service. We put in our infection prevention audits and the education ongoing around that, and the National Neonatal Audit and the Peri-Prem Cymru data is also in here, which includes any admission, term admission into neonatal service. We've included this to time off an outline of our risk register, something that drives us to look at information and data and therefore improvement. And we've also put in our QI quality improvement methodology and a number of programmes that, because of the information and data we've got, we're now focusing on to drive improvement in perinatal services. And we also wanted to share and celebrate the national awards that the teams have been either nominated for or actually won. So I'll leave it there, Chair, and we will take any questions.
Thank you. Dean, would you like to give us to us, please?
Well, for me, it just reflect on the dialogue around the core subject matter now. Going back 12 months, it is significantly different. Quality and safety, we are now getting a lot more data, and more than just the data, we are beginning to analyse what that data is telling us. And as Liz has alluded to, the ownership and the leadership, and I'm not being sycophantic, We have a young lady who has been through all of this with us present. But I think that leadership and ownership is testament to the hard work that it's taken to get us to where we are now. I feel particularly proud of what the unit has achieved. From a quality and safety perspective, I think there is, however, an opportunity for us to look at, which I don't think we've dealt with sufficiently yet, dual site working. That is an area that in which we have to put more focus. And for me, I'm not sure how it plays into a number of areas like unscheduled care, consistency of triage. So all of that, I think, is for quality and safety to now focus on as well. But one of the things I think that Liz has brought in is that, notwithstanding the success that has been achieved, now we know what the benchmark looks like. We have to consistently hit and exceed that benchmark.
Thank you, Jean. And I think we're going to hear more about pathways of care to your two site. I think we're going to hear more about that. That would pick that point up. So I've got Pat, Rena, then Nuria. Pat.
Yeah, maybe a bit of a naive question following what Jean said. I mean, it's great to see the breadth of insight, the data that we've now got to look at. It's great. And the comment that no elements of care are now flagged as a negative outlier. But I was just wondering, obviously we're at a targeted intervention for known reasons, etc. But do we really, have we got that dialogue with Welsh Government now? Do we understand what our de-escalation criteria are and what we're aiming for?
So we have mapped the de-escalation criteria with what we're currently looking at. We do ensure that we share the outputs of this monitoring really and benchmarking. I think we'll work together with them whilst we're in that level 4 escalation to really enable them to have an understanding of what progress we've been made. So yesterday at our IQBD meeting, we gave an update on the improvement programme, etc. Are there clear metrics in there? No, but I think we can provide metrics that will link into both improvement, quality, safety and patient experience.
And I think there are some external factors, Pat. We're waiting for the All Wales maternity assessment data. Right? See what that says about us. That should be at the end of this month, I believe. 9th of February. 9th of February. So that's one. And then, of course, we will be sending this plan to the oversight panel. They have to sign it off and say they're happy. And as you know, the Cabinet Secretary appointed his own observer to this whole process. And she has to tell him that she's happy. So in addition to all the work that we're doing, there are some external factors, but I think, you know, we are making such significant progress. We're very timely, but we need to know, you know, when we could de-escalate. Thank you. Rena.
Just quick ones really. I mean, again, I'm very impressed by the data in this and that we're getting this regularly now, so we know where we are. I just wanted to quickly ask, why are we seeing an increase in cesareans? It sounds obviously, but I don't quite understand why. And I was wondering how much choice plays into that in terms of mother's choice or parental choice, because I wonder in what direction are we going with that? Do you see what I mean?
Yeah, I think Timothy, as the midwife in the room, is probably the one that has the contact and a good understanding.
Thank you very much. And it's a great question. And it's a question that as a community across the UK, we are trying to unpick and understand. We do know that through repeated reviews across the UK around maternity services, there is some fear that is created for women. So birth trauma plays a huge part of why women might choose cesarean birth over other options. We also have an increasing demographic of complexity in pregnancy, so increased BMI, increased diabetes, increased communities in social deprivation, so low birth weight babies who might need intervention much sooner than ordinarily they would. So there are multifaceted areas that we're trying to unpick to understand that and trying to work with women around choice, because choice does play a very large part of the pregnancy and birth that women are experiencing today. And we've introduced many things in that space. One of them is the BRAIN mechanism, which is an acronym that helps women ask the right questions and work on what their knowledge is, their intuition is saying, so that there is a partnership that is developed between the woman and us as services in supporting their pregnancy and birth choices.
I think the important thing here, Rena, is it's about choice, and we support choice, and we support a woman to make the choice that is right for her. That is very, very important, and we've learned that through our review as well.
So Nuria, then Nicola. Nuria.
Thank you, Kathy. You've actually answered one of the questions. We were pointed to the CSERS and actually looking at the demographics of that to understand our composition in terms of the broader areas that we have around population health and the equity agenda. The other point was around the triage. Are there any risks on the regional side of things that we need to be alerted to as a board, was the question I had. And also I wanted to comment on the amount of information in this report. I think it gives us board members a lot of reassurance, and it's the first time that I was pleasantly surprised by a report that gave me all the detail that I needed. So thank you very much.
Thank you. I think from an All Wales perspective around the triage line, I think we are awaiting the outcome of the All Wales assessment, which will make some very clear recommendations. And what I would say is, in terms of our preparedness for that, we are in a very good position in terms of our clinical triage ability, having set up BSOP and have that running now for a year. I think the bits that are yet to be articulated is what the national ask is going to be around clinical input from each of the health.
Can I just ask, which is not really a question, it's more about an example of improvement and how we are utilising what we're doing with maternity actually relying on improvement across the health board. Are there any key lessons that we're learning that we're implementing already?
Yeah. So there's one particular implementation that's going to be going live very shortly around maternity triage. And although we know that there is likely to be a recommendation around a national programme, one of the recommendations that came through from our independent review was having a single point of access telephone number. So if you're happy, Chair, I'll take that point now.
Can we get it in the plan? So that we got it all together. So we'll come back to that, Nuria. And I know, but your wider point about sharing, you want Abby wants to comment on that.
Yeah, thank you, Chair. I think it's a really good example of the things that we know work well in a quality improvement system, and that's what we need to have driving at the heart of our improvement. So really clear data. So the work that's been done to get real-time data and to be able to use it for day-to-day operational management, trend analysis, planning, and you need it at every level. And I think, as we reflected previously, we've got work to do to make sure we've got all of our data in the right place and that we're able to ensure the right people can access it and can use it in the way that we need for all the different purposes. The QI methodology, we've got a really brilliant clinical leader, Claire Dieppe, one of our paediatric ED consultants, who's really passionate about this. And just seeing some of the examples where taking a problem, working through it using standardized QI methodology, and then coming up with the solution and testing it and checking it and having the evidence that it's had the impact you wanted. That's what we saw when we saw the ED improvement. So making sure that that is sort of the backbone of how we deliver our improvement, but also the bit about escalation then. So it does need to feature as part of our planning, our performance and accountability, so people are clear what their responsibilities are as part of it too. So it's all of the components coming together. That will be picked up as part of our model of delivery and improvement as part of the delivery unit that we're establishing. But thank you for raising that.
So we've got Nicola, then Teresa, then we'll close this section and we'll move on to the improvement plan. Nicola.
Thank you, Liz and Kathy. The report is fantastic, really easy to read, really well informed. Thank you very much for that. Wanted to pick up 2 points. I know we've discussed it previously. One's regarding the bereavement midwife. I think her name's Chrissy. She does some incredible work. I have popped along to 1 or 2 of the community events just to see the impact that she's having, and it is wonderful. What are we doing around training other midwives so that there is a cover when she's on leave or on sickness, etc.? And the other thing I wanted to pick up was regarding the bereavement room. Have we done any work around that as well, please?
Thank you very much. Yes, there is an awful lot of work that's going on in this space. So with regards to creating capacity within the team, we do actually have other members of our team earmarked who are supporting the bereavement pathways and have received training of excellence in order to do that and support our families in that space. The other thing that we do on an annual basis is part of our training and education programme. Every midwife, every obstetrician within our service receives an annual bereavement update in terms of types of care and things that we might need to consider around the loss of a baby. And in terms of the bereavement room, I wish I'd brought photographs because we've just had our new bed installed. And we've got the Arts Council coming in who are about to start some artwork in there for us. We've also been working with the charity For Louis, who are also supporting some other pieces of equipment that will help us in the delivery of our bereavement service for our family. So everything's come all at once, which has been very exciting because there's been a lot of work and a lot of dialogue in the leading up to that. But the new bed is absolutely wonderful and will make such a difference to our families and that time they get to make memories of their baby.
So Nick, I know you've been following this all along, so I'm sure you'll be pleased, really pleased to hear that. So Teresa, last one to you.
Yeah, I was going to ask if there is a risk to our workforce capacity and how we're balancing that with choice when it comes to cesarean sections, and if we are looking at how we mitigate that risk. So that's one question I had. The other question, I can't remember now, but yeah, I'll come back to that.
No problem. Thank you very much.
It is a really good question, Teresa, because every maternity unit across the country is now responding to choice, and that does mean that there is a different level of care that's required depending on that choice. We are looking at particularly at the anaesthetic service and the input from the anaesthetic service. We also are looking at the impact on theatres. So, you know, it is an ongoing process. I think we will learn from other units across the UK as well, but definitely something that we have to consider for future and will be considered across the UK.
Can I also suggest that EQI, so equality impact assessments, are carried out for the perinatal quality improvement programs, because I couldn't see that on the paper.
Just to reassure you, yeah, we absolutely do. Yeah. Thank you.
Thank you. So we'll conclude this piece on the report again by thanking you all very much for what is a really rich report. And I'm sure it's leading edge now in terms of the amount of information that's coming through. So we do need to check that. So we send our congratulations to everybody involved. We're asked to take advice on a number of the recommendations, to take assurance on others, and then those we are alerted to, those are going to form part of our discussions on the improvement plan. So are we happy to take the advice that's set out? And then to take assurance requested, and then we will come back to the alert. So at that point, then we will move on to the improvement plan.
Thank you, Chair, and I will start to present the improvement plan, but my colleagues will also come in on it. So it sets out how we're going to respond to the findings of the independent review, the family-led review, the advice report, and also will address the All Wales assessment, whatever recommendations come out of that as well. We're really clear we want one improvement plan to drive the service to where we want to get it to. This plan is an organisation-wide response and reflects the work that's already been done, and the improvements that are already underway, but the further actions that need to be achieved for us to be an outstanding service. We deliver around 3,500 births a year, Kathy, and we host the tertiary neonatal unit, and we support babies from 22 weeks gestation. As I say, the review was published in July last year. We've got 10 priority recommendations, 69 detailed actions, and we want to give you the opportunity to see how we intend to deliver all of this. Some we've completed, there's some more to do. It's not just to simply address the recommendations, but we wanted to transform the service and to ensure that it's one that's safe, compassionate and reliable every day for every family. So to support this, we've strengthened our governance and we've done that substantially. Part of what you've just heard is through that governance process. I've said we've got 2 perinatal champions, but we've now set up the Perinatal Improvement Programme Board, which our Chief Exec is chairing for us and oversees the programme and reports directly here on the 4 work streams that we've established. Each of those work streams is led by an exec colleague. So those work streams are clinical safety, Richard leads on that, family engagement, myself and Richard lead on that, workforce leadership and education, Tina leads on that, and governance and assurance, and Hazel leads on that. So I just wanted to hand over to each of the work stream leads for them to tell us where we are in those work streams.
And members will have read the paper in detail. So if you can just the highlights that you want to bring from each theme, that would be really helpful. Richard, so over to you.
Thank you very much. Thank you, Jan. Thank you, Liz. Workstream 1, the clinical critical safety actions. I mean, board members will know from both the paper and the accompanying chart the volume of work that's gone into this and the level of detail that sits behind it. There are 8 work streams that sit within Workstream 1. Those are triage, induction of labour prioritisation, 2 site working, neonatal radiology, multidisciplinary training, investigations, learning and actions, senior level supervision and oversight, and escalation and raising clinical concerns. And board members will see that for certainly 2 of those areas, the actions have been completed. And for the others, there are clear timescales for completion of those actions. What I would propose that we do, though, with your permission, Jan, is to highlight maybe 2 or 3 areas within these that we can focus on a discussion. And the first of those is triage, which we started to touch on a bit earlier. Maybe I can hand over to Kathy for that one.
I thought it might be helpful to try and describe what happens now, to give a flavour of how we are mitigating risk and responding timely to escalating concerns within the women. So I'm going to present a woman who's 32 weeks pregnant. She lives in the community on the border between Swansea and Port Talbot. And historically, contact numbers were inconsistent and access points meant women sometimes rang non-urgent numbers, left messages on community phones, or contacted the wrong unit, which led to delays in their receiving treatment. So we are implementing a single point of access telephone triage system, which has a menu of options for the women depending on what they are contacting us around a query or a concern. But then the way that we are providing that now and that pathway is resolving and mitigating those risks, because what they are doing is providing us with a single clear route of urgent concerns, regardless of where the woman lives. It's given us a structured choice options based on gestation, risk level and symptoms. It gives immediate routing to the correct clinical environment, and also gives us bilingual standardisation messaging, which reduces confusion for our population. And what it does also do is give us consistency across the whole of the health board. So when she rings, the first thing that she'll hear is, if you are experiencing vaginal bleeding, abdominal pain or concerns about your baby, please press 1. And that takes the women straight to our urgent access emergency triage service. And what that then allows us to do is have clear identifications of critical safety concerns, immediate triage without delay for her, and then there's no reliance on knowing which site covers her care and needs. And that automated routing gives us access to timely escalation of concerns for that woman, and prevents unmanned phones being answered or being redirected to voicemail or then having to be redirected around sites. So it gives us immediate clinical contact, eliminates delays due to call handling variation, and is using an evidence-based triage system in order for us to address her immediate concerns.
We'll be able to pick up questions in the section.
On that. One thing I would just like to ask, how are we going to dip sample it? How are we going to know that it's consistent and reliable? What are we going to do?
So we already do audit our telephone contacts, and we did test because we're not just looking at our ability to respond to that in the correct way using the pathways. It's about the compassion and the kindness that we observe in those phone calls, so that we will continue to do that.
Back to you,
Thank
Richard.
you very much. So if I might, the next one, address particularly two-site working, which Jean referenced earlier as well. This is interesting. And while the work stream is entitled two-site working, it doesn't really reflect the breadth of the work being done in this area and the scope of the team's ambition. And so in future, we'll be referring to this work under the title of escalation processes for pregnant women cared for in non-maternity settings, because that far better reflects multiple sites, multiple units, and multiple different interactions that we might have with pregnant women attending. The first piece of work that was done with this was the development of a standard operating procedure with the intensive care unit at Morrison Hospital, recognising that need for escalation between the maternity units, either a Singleton or a Neath Talbot, and the intensive care unit. And that's been developed jointly and has been implemented to provide clear guidance for the management of pregnant or recently pregnant women who require critical care input. That SOP is now being expanded to include all non-maternity inpatient areas, so not just intensive care, and to make sure that that escalation process is consistent across the health board. And with that regard, we've also been liaising with Liverpool Women's Hospital, which is the only other hospital in the UK that has two separate sites, a two-site working arrangement. You'll see in the spreadsheet the mention of a safety huddle, and just reflecting on that, I just wanted to bring to life what some of this means, because I think maybe with a bit of detail added, board members will appreciate what involves. So the safety huddle is a tactical operational meeting that occurs twice a day. It's held on Teams and involves every single one of our sites. It's led and coordinated and chaired by by one of the senior ops managers, and is attended by not only those sites, but the site leads, but specialty leads as well. The meeting in the morning feeds in immediately afterwards to the national meeting. The meeting that is held in the afternoon is typically also attended by the executive on call, who's gold for the day. When things are busy, we'll have an additional meeting at 9 p.m. and an additional meeting sometimes at lunchtime at 1 p.m. Since July 2025, maternity in the presence of maternity services has been at each and every one of those meetings. And that has been a substantial difference in the way that there's that maternity presence during the on-call. So I was reflecting that safety huddle might imply a group of individuals standing around a whiteboard, but it's absolutely not the case. This is our highest level tactical ops meeting in the organisation that flags up the highest risk details. So this is where we'll have the updates on ED, the number of ambulances outside, the number of handovers, but also maternity. And I was talking to Kathy last week, and we'll talk a bit in a second about the process that has been put in place to flag the presence of pregnant women in our services. And Kathy was telling me that while we've had maternity on those operational calls on a often 3 times a day, sometimes 4 times a day basis, pregnant women have been mentioned at those meetings, but reassuringly on each and every occasion that's happened, the team have already been made aware of those by the clinical team caring for the patient in those circumstances. So it's not what we rely on, it is a backup, but it is a very highly high level ops meeting. Muse scores comes up as part of this as well. And Muse scores, the maternity early warning scores, were launched in July 2025. They were rolled out across our maternity services by the end of that month. And in the intervening time, we've been rolling them out in the area. So currently we have Muse rolled out in all our acute areas at Morrison Hospital, so the assessment units as well as ED. Keeping an eye on the screen, because I know Nadia joined. I wanted her to talk about particularly some work that didn't want to steal her thunder, but I know she was in clinic and may not have been able to join. One of the things that Nadia's been leading on is in putting that those Muse the Muse chart into ED. Is a piece of work around a maternity escalation pathway, and that actually went live 2 days ago. I can tell you a bit of what that entails. What they have done is they've provided Muse training for ED staff, medical and nursing, and that's been completed, which has included the maternity visiting ED triage as well to help facilitate that training. The Muse chart is visible in the triage area as a prompt, and there's ESR learning and teaching video that's been developed for staff to learn how to use the Muse chart if they haven't been able to attend the session in person. During the streaming process, healthcare assistants in ED have been informed to commence observations on the Muse chart, and that the pathway is very clear on details on when and how to escalate to the obstetric team, and that will ensure timely senior involvement, early recognition of deterioration, and rapid referral to maternity. Now, this has been a paper exercise. This has been a training that has gone on, as I've suggested, in terms of the visits. But in addition to that, we've also provided obstetric simulated teaching to the ED, which has been provided by the maternity team, which has encompassed a number of critical maternal clinical scenarios, ranging from a critical incident of a collapse in a pregnant woman to other scenarios, including eclampsia of childbirth, because we appreciate it might happen. So maybe I could bring some of those things to life for you in terms of examples about recent cases in the last few months. We had a pregnant lady who was admitted to our maternity ward who developed a severe lower respiratory tract infection that necessitated transfer to intensive care unit. This was escalated promptly. It was managed collaboratively with maternity staff and the medical team, and daily discussions were had with the teams regarding in line with the new SOP. On discharge from ITU, care was handed over from the ITU consultant to the obstetric consultant directly with an appropriate plan in place. Second case, in terms of a lady presented to ED with respiratory symptoms, that was recognised early in the course of her attendance in ED, and there was a plan put in place that involved obstetric team, the ED team, and potentially the ITU team as well, as preemptive plans should you require admission to ITU. Now, happily she didn't, but those plans are put in place in advance of any escalation being required. Nadia, still hasn't joined me. I wanted to give me one further example, which is in terms of what the impact of the new pathway in ED will make. So Nadia's told me that, given an example of a 26-week pregnant woman who attends triage with severe headaches, generally unwell, and is found to have a high blood pressure. So the concern would be about her developing preeclampsia or eclampsia. What happens next now is that on the Muse score, the blood pressure will trigger a higher score, giving a total of 4, which will automatically initiate an escalation for senior medical review, a discussion with the obstetric team, prompt assessment for hypertensive disease of pregnancy or early preeclampsia. And the difference between that, Nadia tells me, in terms of that and the current process, is that's far more rapid escalation. It's done in a systematic way according to a scoring chart, where we're not reliant on individual knowledge, but a score. There's far less risk. The patient presenting in that way might be attributed to have a non-specific headache rather than really early recognition. This might be something very much more serious. Is there anything I've missed or you wanted to add to that?
You did that very much.
I'll stop there, Jo.
Thank you. So do we take questions or comments from Richard and update on work stream 1 then? Jean?
We would still like to come back to the two-site working, although it's heartening to hear the systems that are now put in place. I think for me, I'd like to have visibility of what the learnings look like, what the consistency of application has looked like, and has there been any harm to anyone that we were too late getting to? So it's the visibility of the consistency and the systemic approach to managing that two-site unit, and it would be really useful to know how we compare and contrast to the Liverpool model.
I think clearly the perinatal improvement programme board needs to make sure we're closing the loop on the things we put in place. So where we've got something that's closed, it can't just be a closed, right, we've done it. It is about, and how are we going to monitor impact for the period in which we'll need the program in place. So we'll pick that up and make sure that comes back, Liz, as part of the updating from the committee. That's a really helpful point. Brilliant. Yeah, really.
I'm really conscious how much is in this report. And my intention was to go through each of the work streams. I don't know, Chair, whether, I mean, I think We particularly needed to highlight the clinical safety issues, of course, that's a priority for us. I think we've outlined family engagement and how we're going to undertake that. The bit for me in that, and the bit that I've got responsibility for, is that compassionate response to incidents, birth trauma, etc. And we've outlined all of that in there. The workforce education and culture is around training, development, opportunity with HEIW and Michael West to provide training and ongoing support for our teams. And also from a governance and assurance perspective, I think we've evidenced some of that here. And with Hazel's team, you know, we will continue to strengthen governance and assurance. I'm just really conscious of time and, you know, didn't want to.
I know, it is important though, before the board sends this, hopefully, approval in principle to the oversight panel, the board needs to assure it that you've asked all the questions you want to, that you've got a sound understanding of how we're implementing the recommendations. You know how actions will be evaluated and through what route they'll go, whether it's quality and safety or through the programme board. And there's nothing that you think now would be left to individual practice rather than a consistent approach across the system. Because that was one of the key issues previously. Too much was dependent on individual practitioners. And this is all about, do we now have system assurance that we've got policies, process, systems, practice that's consistent? So Kathy, would you like to come back on that?
Yeah, I'd like to say I really am very proud of what we have achieved. And I think to when I started back in mid 2024. And I think that what I see now is completely at the opposite end to where we were. I feel very assured that I am aware of my data and the impact that's having. I'm very assured around our governance process for reporting that, and I'm very assured around our clinical team's engagement in driving improvements, which is data driven, and on using the feedback from women and the learning that we are gaining through their very generous feedback. I think the only other thing I wanted to tell you is I think that what we have achieved here has been recognised across Wales. We have been one of only 2 teams in Wales that have been selected around a quality management system, learning and development programme that we will be testing for the rest of Wales. And we commenced that this month, and it's a very exciting programme. We're all really quite energised by what that's actually going to give us and what it will give to our health board as well, because that learning will actually be implemented across the health board.
Julia.
I think that as a board member, I can take assurance that we've got systems and processes in place from what I've got in front of me. I think it's that point that you've made about that continuous and continuous evaluation of our systems and processes, ensuring that that's embedded into the system for assurance. Because there's a difference between the reassurance that you can provide and the assurance that you have to. The effectiveness of those processes. So I think that would be absolutely.
And I think that's why we've got an improvement programme. It's a significant piece of work. We are going to monitor it through that programme. But we still have to be very clear about how we know how our service is doing and how we triangulate that monitoring that is business as usual, if you like, with, so if there was an incident that had been, where there was a difficulty in the 2 site working, etc., we would bring it into this perinatal committee and the perinatal report we would know, and then we would, you know, and then we would look up what improvements we've already done and what more do we now need to do. So I think a huge amount has already been achieved, but there is so much more to do, and that is a significant piece of work for us as a whole organisation, with learning across the organisation. But that is why the Perinatal Improvement Programme, alongside the monitoring, will report into board every quarter. You'll see where we are and what updates we've got. We've got to triangulate it with the information that we want to have and hold. Thank you.
Other questions or comments? Jean, does that assure you in terms of how the board, QSE, programme board, will be able to take assurance on the evaluative data? That's a really important thing that's got to be ongoing, as Nuri said.
Do you want to come in? Yeah, just a quick one. In terms of the birthing centre in East Talbot, obviously it is a separate unit. I just wondered, in terms of the way, the consistency of approach, are we enabling that in terms of
joint and moving staff across maybe. That was just a confirmation, really. I presume we were. And the other thing I was thinking, well, if we accept this plan today, which I think we're going to, obviously there are known, as it says in it, financial implications in this. Are they already fed into our financial profile for next year? Because clearly we need to make sure they are, because we don't want to go backwards, do we? And then the last thing was really, I'm presuming in terms of finances, some of the things that have been proposed here are frankly invest to save. If we have less serious incidents and whatever, then we'll actually be saving money in the long term and obviously saving lives. So I really think it is important that we've got that, you know, there in our plans.
Yeah, thank you, Rena.
So our systems and processes are set up across the whole of the perinatal service, and we've brought perinatal together. Neonates used to sit in child health. We've now brought the whole of that service, whole pathway together. So everything that we do in the midwifery-led units, both at Singleton and Newport Talbot, and we hold the same governance processes. Do staff rotate? They haven't since we reopened the unit a year ago. We are having discussions whether that is the right model or whether we should offer that rotational programme to keep skills up, etc., etc. So that will be part of our ongoing monitoring. The financial implications we have discussed, and they are within our. We know what the risk is to us, and it's in our plan.
Abby, do you want to add on how we sort of play this into the 26-27 planning process?
I think a lot of the things that you've heard have been built out by getting the right staffing model in place and the right staffing numbers, and have our succession planning around that, and making sure we're taking our new midwives and we're training, etc. So a lot of the cost has already been built in with the investment that was made. I think we're getting a lot of good support from other agencies that are supporting and helping. So HIW, giving some of their time and capacity to support us. And much of what we've described is being done in with the team as part of their ongoing training and development. So it doesn't actually come with a new premium other than freeing up staff for time to do this. There are two areas. We know that one of the issues to do with the increase in number of women who need to go into theatre for their birth as a result of cesarean section, we know physically the environment around having only one fit for purpose theatre in the area is not where we want to be, and that will be part of the capital conversation we're having with government. It's not a huge scheme, but Welsh Government, again, clearly very aware of that's something we would need to do. We would need to do the revenue of that within existing resources. But at the moment, if you're going out of the Labour Board area to main theatres to deliver your baby, include C-sections or any other surgery that may be required, that's time of staff away from the ward. So actually it might actually be beneficial in terms of staffing if we were to get that. We know that we're fortunate there is physical space in the right area for us to do that. And we are progressing those conversations with Welsh Government earnestly. So that's the other area that we're pursuing as part of that conversation. So from that point of view, we've got these things built in. The one thing I'm just going to reflect on, Jan, because again, I think it was very powerful when we had the report, and it comes back to our population and our population risk and the deprivation. So again, referencing what more we can do to support women to be healthy weight going into conceiving, and that's part, Jean, of that whole bit around starting well. And we know that is a challenge in some of our populations. And again with mental health support as well. So again, those are things we need to build in as part of our role but cross-reference across here as well.
Thank you. So if we can move to the recommendation, before we move to approval, can I just take you to the end there? And just to confirm that on the triage recommendation, that's it. And you'll know that there is going to be an always perinatal assessment exercise, and Welsh Government is going to look at a national approach. But our members assured that what we're doing from February with a 24/7 single point of access does that capability. And then on the paediatric radiology, as you know, it needs a regional solution sustainably, but we have got an interim measure in place. Is that sufficient mitigation? So then can we move then to approval in principle and to send the plan to the independent oversight panel for scrutiny? And we will attach to it the examples, the work examples that the board has heard as a means of assuring itself around reliability and consistency of service. And we'll set out the evaluation mechanisms to make sure that we continue to know. And we will receive quarterly reports at board level. QSC will take the detail for us on our behalf around the perinatal committee, BAU, and then we have formal programme board structure. So can we take assurance then that we do have a comprehensive plan in place, and particularly making sure that the actions we're required to take, we do, that we can take assurance in the progress we've made so far. And I think we've talked about the very significant progress we've made, and that we do have robust governance and assurance structures in place. I think that at that point we will break for lunch, because I think that is actually a positive point to break. And again, Kathy and VNT, please think back to everyone involved. Thanks and congratulations. Appreciate it. We know how hard it's working, and well done. And we look forward to hearing even further improvement. Thank you. We'll break for lunch now then, and we will come back at 25 past. Yes. Oh,